Welcome, everybody. Thanks for attending the webinar on is CBCT right for you in your practice? I appreciate the opportunity to be here to spend some time with you and share some knowledge. Hope you find it beneficial and informative. Throughout the presentation, my email will be on the bottom of the slide deck here, so feel free to take that down and reach out if I can be of service. So we will get things underway. So this is Papa Clower. My grandfather, he's 96, and he's a true pioneer. He's a dentist. He started practicing, he practiced for 50 years, and he was doing orthopedic development in the 70s and treating kids with obstructive sleep apnea before we even knew what obstructive sleep apnea was. He didn't have the technology that we have available to really evaluate children. So, you know, I give this lecture and information from a tremendous point of humility in that, you know, I didn't know what I know until I was taught it. And so if I get rolling on some topics, just know that, you know, I'm honored to have learned from some great people. And, you know, we stand on the shoulders of the giants before us, as they say. So, that's Papa Clower, still humming along fine and 96 years old. A fun fact about him is he actually started wearing gloves before anyone else and lost patients because patients thought he had a disease that he didn't want to give to them. So they didn't want to go to him. And now, given the current state of PPE, you know, he was way ahead of the game, that's for sure. So this is my beautiful family, my wife, Haley, and then our four kids. We have a 7, 5, 4, and 2-year-old. So things are busy at home and busy at work, and that's how we like it. Throughout the presentation, if you want my slides, handouts, and you know, some reading, you can text Clower to 21000. And for those of you who are international, you can just shoot us an email, and we have get you our slides and some handouts that I'm going to share, and some books or reading resources if you want. So you can take a screenshot of that or shoot us a text, and it'll gather all your mailing information and such. So do you want to go through some disclosures for you? So I do own a consulting company. We consult for practices that are interested in implementing TMJ and sleep into their practice. So we work on the business systems. We host retreats and events for those doctors where they can bring a doctor in. That's another medical specialist to help collaborate. Next one's in Jamaica, and it's for our clients only. So that's, you know, a disclosure. And then I consult for dental imaging technologies. I am receiving an honorarium for this webinar. And these are my thoughts and my opinions. And so I do have a lot of data that I'm sharing, but, you know, anytime an opinion stated, that is mine. And then I have a sponsored by and supported by 6 a.m. Run. It's a supplement company for runners. I like to run a lot, and it's a great amino acid based supplement for training and stuff. On the bottom here, if you want a 20% off coupon, just use Clower TMJ. I don't receive compensation from them. I just get some free product and stuff like that, and kind of test it for them and talk to them about it. So those are my disclosures. So the objectives, we're going to talk about 2D versus 3D, the differences and the benefits, factors in selecting your CBCT equipment, review of different applications of the technology, considerations for diverse patient populations, merging data sets, and limitations and radiation concerns. I'm not going to go a ton into what computerized tomography is and how the cone beam, all that, like the kind of, as I would say, boring science stuff. You do need to know that, but I kind of wanted to make it more applicable, and stuff about implementation and how to know if it's the right technology for your practice. It's a great technology, been around a long time. So my practice, just to give you a kind of frame of reference, we are 100% fee for service. We courtesy bill medical insurance. So 100% of my time is spent treating TMJ and sleep. And the saying I often say is cost is only an issue in the absence of value. So we get away without being in network with insurance because I feel if we build immense value all the way through, patients accept treatment. And I think find with this type of technology, it really gives you the the ability to show value and really illustrate what a patient needs and is looking at all the way through a treatment plan. So I see patients Monday through Wednesday in clinic. I see about 35 to 50 people a day. We'll start about 35 to 50 cases a month for TMJ or sleep. And it's myself. We have a nurse practitioner, a myofunctional therapist, and then 5 clinical assistants, 4 admin, and then 1 practice development person that helps with our growth strategies and implementation with kind of liaison to the doctors that we work with. And we'll welcome about 60 to 75 new patients per month into the practice. These are the conditions we commonly treat, and that's what makes up my my everyday life and practice. And so I'll be speaking about other uses of cone beam for sure, but this kind of gives you a reference point as to what I'm dealing with routinely. So as we start off, what is one of the first diagnostic tests we perform on an asymptomatic new dental patient? So a patient comes in as a new patient in general dental population. What's one of the first diagnostic tests we perform? It's a full set of x-rays. And our world is the same in the TMJ and sleep and orthodontic world. Is if we're evaluating a patient, we got to see what we're evaluating. And so we will take a series of x-rays, whether it's a cone beam, limited to just the teeth, limited to just the jaw joint. Really depends on what the indications are. But you first need to evaluate the patient and then order the appropriate imaging. We can't just image to image. We really need to have indications for that image and know what we're looking for and order the appropriate image. So every patient I see, I will evaluate, meet with, and see before an image is taken, because the patient needs to be well informed of what that image is, the risks and the benefits. And so that'd be my recommendation to everybody, is make sure that you are not just imaging to image, that you discuss it with the patient and you're ordering the most appropriate image. So in our world, again, typically we will order a CBCT low dose. We'll kind of show you guys the exact parameters that we use in our practice for our, I guess I would say, our most standard evaluation of someone with temporomandibular joint pain, locking, or suspicion of obstructive sleep apnea. And this picture always resonated with me, been using it for a long time, in that this is basically what we get with cone beam versus traditional. So as you can see on the screen left, holding the pineapple, that's what it looks like in 2D. The other 2D version of it looks like the shadow in the back. But in 3D, you can actually see that at the same time, you can see that 2 objects are being held just in different planes. So I really do feel that with the 3-dimensional imaging capabilities, we really can truly see everything that we want to see. It's interesting to see the standard of cares being dictated by this, and a lot of that is dictated legally, but I'm told by the attorneys in regards to standard of care for dental implants, if you don't take a cone beam before placing an implant, that by many is deemed below the standard of care. I don't know why you would place an implant without seeing everything. I know that I personally wouldn't want an implant placed without without a cone beam. I wouldn't want a jaw joint evaluation without a cone beam, and I wouldn't want my child to have an orthodontic evaluation without a cone beam. I understand the risks of the radiation, but the dose is very minimal, and we'll discuss that. But what I would urge everybody is to read about it, understand it, and draw your own conclusions from the published literature and data, so that you know what you're recommending for your patients and your loved ones. So here's a great example from today of the benefits of 3D imaging. So here, this patient was in this morning, and he was in for apnea, but he had pain on the right, and the referring dentist thought it was related to muscular pain, probably due to bruxism due to his apnea. So we said, yeah, that's reasonable. Let's do an exam. Well, the dentist took PAs of both of these structures, but the buccal bone is so thick from his buccal tori, it didn't quite show up. So you can see here on tooth number 3 on the upper right first molar, he's got a periapical abscess going into the PDL space of tooth number 4, upper first premolar, upper first molar, and definitely an issue there. And then right below on tooth number 30, the lower right first molar, you can see here he's getting some root resorption and has a radiolucency starting. But then as I scan through, you can actually see that he had a post placed, and the post is actually outside of the root. So he's perforated on the post. And so both of these, this has a perulus actually that's forming on the lingual. It probably wasn't there when the dentist evaluated him last week, but he would have seen that. But it's you definitely can tell here on this image that there's a perforation. And so without that 3D technology, you might be blindly treating some muscular pain, and maybe just doing the upper tooth, maybe taking out just the lower tooth, really wouldn't be able to evaluate those like we are here, because the dentist who referred over is a really good dentist, has good reputation, just didn't have the capabilities of seeing these structures in 3D. So here's the typical image that we take in the practice. And so this is a fly through, and as it flies through, you'll see the anatomy that we're evaluating. So first it'll go through the nasal passages, and you'll see the turbinates, the nasal septum, and the maxillary sinuses. So it's really good to get out an anatomy book as you scroll through these images and really understand what you're looking at, so you can discuss it with the patient. So as it flies through, you see the nasal septum, you see the turbinates, and then the maxillary sinuses, and then see it takes about a 90-degree turn and going down into the airway space. And the airway is not this PVC pipe; it's a 3-dimensional muscular tube, and there's the epiglottis. So really, we're evaluating this dynamic structure in a static position. So while the airway features cool on these cone beams, it's not the end-all be-all, and it really doesn't tell you if a patient's apneic or not. It doesn't tell you if they snore or not. It just gives you a static representation of a 3-dimensional dynamic image. And so, not to underplay its significance, but a lot of people, with me being in an airway practice, think, oh, I use that airway feature a lot. And we do use it every time we evaluate a patient. But what I usually tell the patient, if it's extremely narrow, I said, wow, your airway is really narrow. We don't know if that confirms it collapses or not, but I can probably guarantee you it doesn't get any bigger than that at nighttime when you are relaxed and the muscle tone is decreased, during sleep. So again, we use this as a tool to put together our treatment plan and to comprehensively evaluate the patient. But I'd be lying if anybody would be lying if they say it's the end all be all of evaluating these patients, and especially sleep patients or TMJ patients. So going into some of the details of these images is, I think it's important to understand voxel size. So the lower the voxels, the greater the resolution. You can see better, and also the higher the radiation. So if we have an image at 0.2 millimeter voxel size, it's more detailed, more finite. You can see, periodontal ligament space better, and just higher representation of what's going on. And then as you go up to like a 0.4 millimeter voxel size, it gets a little grainier, not as easy to see things. So this voxel size you can change every time you take a cone beam based on what you need to see. So some orthodontists I know, for instance, for repositioning appointments where they're checking root angulations, they'll up the voxel size, make it a little more grainy because they don't need that specific detail. If in my practice, if we're checking condylar position with an orthotic or a sleep appliance, we'll increase the voxel size because I'm generally looking where the condyle is in space versus is the cortical lining intact all the way throughout the condyle, and looking at abscesses on teeth. So our main image is at that 0.3 millimeter voxel size. But what's nice is with most of these machines out on the market, you can change that voxel size based upon the needs of what you're trying to accomplish in your evaluation. So make sure that's something you understand, and you kind of get it dialed in over time as you learn more and more about how you're going to be utilizing the imaging. So field of view, increased field of view equals increased dosage. So you want to know what structures you want to capture. You definitely don't want to, and we see some people doing it, and I think it's just because the machine got set up and they got to work, but you don't want to just take the biggest image possible every time. There's a lot of interpretation of what you're liable for in terms of reading the images. I'll kind of share with you in a minute some ways of protecting yourself and the patient in terms of the image you gather, but really take the field of view of what the areas you need to see. So don't take a full scan if you're just trying to look at a maxillary tooth. I think it's appropriate to take a whole maxillary arch if you're looking at a maxillary tooth, but you can even focus it to the left side versus the right side. So you really want to understand that scan time and patient movement. So there's scan time, and that is compromised of when the unit is actually capturing the picture, and then the time in between it. So our scan time might only be actually 4 seconds of emitting radiation, but the scan time's 8 seconds because it's alternating. And so that scan time you want to have dialed in, because it's really, really hard to have a patient sit super still if they're elderly, their balance isn't good, a child, they're in pain, they're claustrophobic or whatever. So you really want to take into account, okay, what's the lowest amount of scan time I can take to get the information I need and decrease the chances of having to retake it. Especially when you're buying a unit, I would physically watch one work, see one work, and ask good questions, because when I was buying one, I'll share a slide in a second. I was told that the scan time was one thing, and when I actually tested it, it was dramatically different. So positioning, sitting versus standing, that is something to take into account. Some people think it's easier to stand and hold on to 2 bars as the image goes around. I personally think it's easier to sit. I think it's more comfortable for patients. They feel more secure, and you don't have to worry about someone moving around or swaying. As humans, we all have a sway, so we're constantly moving. And we've documented that on a MAT scan. And so I think sitting down gives more stability, but there are indications where standing would be better. And so you definitely want to take that into account based on your patient population and what you plan to do. And then informed consent. Make sure you're educating the patients and you're comfortable talking about the dosages and the considerations for that when you give it to patients. So a lot of times I get asked is CBCT right for you? And in my opinion, this is my opinion, and I want to make sure I state that, really it comes down to 2 questions. Do you consider yourself open-minded? I know a lot of us do things the way we've always done them, but if you consider yourself an open-minded person, I do think this is something that you should look into and evaluate objectively, and I think you'll find that it really is a no-brainer. If you're going to be practicing for 2 more years, I think it's a no-brainer to invest in this technology or make sure you have access to it as your treatment planning cases. Because if you're a general dentist and you do crown and bridge, or you do endo, or you do implants, whether it's the restorative part or the surgical part, you take out teeth, I really don't see how you could practice without it long term. So if you're going to be practicing in the next 2 years and your state, country, wherever you practice allows you to have it, I would seriously consider getting it. If not, consider how you would have access to one, because there's so many indications. I'm going to show some today where we see things that we otherwise wouldn't. And you can only see what you know to look for. And once you start to see these things, stuff is around way more than you may otherwise believe or think. So the 2 most common objections I get I hear, I should say, is cost. Like I said earlier, cost is only an issue in the absence of value. I mean, I can send you a worksheet on the feasibility of implementing this into a general practice, and how, as long as you use it, it gets paid for. If you charge appropriately for it, the technology gets paid for, as it should, because it's a tremendous value add to your patients, and really enables you to clinically, render a great treatment plan for your patients. And radiation concerns, and that's a valid concern. And I think once you educate yourself on the dosages of what we're currently doing and what we've currently been doing for years, and the dosages on the cone beam, while not all radiation is created equal in terms of cone beam and the culmination of it versus fan beam CT scans, generally speaking, the data is telling us that the radiation dosages are quite similar, if not less, than some panoramic films and full mouth series. So, this is Cavo Kerr's line of it. And, you can have cone beams like the OP3D that are great for general dentistry, orthodontics, and endo, and some implants. And then it goes up to the OP3D, which has a cephalometric analysis, and has some other features that get into more of a larger field of view, get in more for the maxillofacial surgery type indications. And then the ICAT Flex, which is what I have, and it's actually the same unit that ear, nose, and throat doctors use. So my ear, nose, and throat doctors can actually use my image when I refer them a patient for their image guided sinus surgeries. So the data is good enough that they're using it for their image guided sinus surgeries. So the good thing is there's a lot of options out there, and you really kind of want to educate yourself so you pick the right machine for the right practice. And then there's also panoramic with Ceph, panoramic with 3D, and then panoramic with Ceph and 3D. So really you can configure these things to fit your practice's needs. And it really comes down to what your specific goals are. Along the way, please use the chat feature. I'll get to questions at the end. I did some time to answer questions. So there's a Q&A section. So definitely feel free to put your questions in there. So how to pick a unit. So I got some talking points here. So you want to look at your procedure makeup and the potential procedures that you want to do. So let's say you're going to start taking out wisdom teeth, or you're going to start doing implants. Also look into the future in 3, 5, 10 years. What do you think you're going to do more of? Are you going to consider start placing implants? Are you going to hire an orthodontist to come in and see your patients? Are you going to get into TMJ and sleep, which so many people are, and there's so much of it in your current practice. I'm definitely believe that whatever you do in general dentistry in your practice is you can do in TMJ and sleep in your practice. And I've seen that. I've proven it myself in the practice I came through, and then many of the clients we work with have done the same thing. So if a practice is doing $1 million in general dentistry, in my opinion, there's $1 million worth of people you can help in TMJ and sleep. And that money is a direct reflection of the value and how many people you've been able to impact and help. It's, as we all say, it's not all about the money, it's about helping the people, but the money is a reflection of how many people you help. You do need to look at the footprint. Okay, so how much space do you have, and what's the footprint in your building? Can you renovate the space? Do you have to fit it in a little nook and cranny? And then what's the site mapping look like? How many feet away do you have to be from an operatory? So you have to have a site plan so that you know if a specific unit will actually work in your practice. And then scan times. So you want to make sure that the scan times are such that you're not having a patient sit for a really long time in there. And so if you have a unit that stitches, it takes the upper half of the scan, and then it takes the lower half of the scan, and a patient could have to sit there for up to a minute to get a scan. And that's what certain units on the market do. And they don't really advertise that piece of it, but that's a pain in the rear to have a patient sit for a whole minute to get a scan. So And then rendering times. Rendering times is how long it takes to compile the data. I like our iCat because I can follow a patient from the iCat unit back into the operatory, and the scan is pulled up as I'm having a conversation with the patient. So our rendering time is less than a minute that it takes to compile the data. Some units are 3, 4, 5, 10 minutes to render the data. It depends on the technology, the software, but also depends on your server network and everything as well. So in our office, we have computers that read the imaging in every operatory. So we have 6 operatories or treatment rooms, I should say. And so every computer has the capability of evaluating the scans, because, some days we're taking, 10 to 15 images, and I want to be able to look at them with the patient in the patient room. So the rendering time is extremely important in my practice. So I wanted to find the unit that had the quickest, the fastest, and the most predictable. Software. So there's so many great softwares out there, depending on whether you're doing ortho, doing CAD/CAM integration, implant guidance. We use the Treatment Studio software. There's new one coming out, and again, when you look at a software, look at all the features that it offers in the package, and take some time to really understand them, because you can create some cool videos. You can do a lot of overlays of 2 previous images, take screenshots. So like a lot of the softwares that we own, our iPhones, our Gmail, all that stuff, there's so much built into it that we really underutilize. So I would definitely take some time to understand the software that you get with your cone beam unit, because it will really help enhance the value of it. And then integration and communication. So any system that you use, call your vendors and make sure that the systems speak to each other, so that you don't have like 2 awesome pieces of technology, but there's no bridge to communicate them. Thankfully, the bridges are becoming more and more prevalent, and we don't see that as being a great issue, but it's definitely something that you want to check, just so you don't get caught off guard by not being able to integrate something. And then we said it before, field of view needed. So make sure that the image, the unit that you buy, can acquire the field of view image that you need for your practice style and what you want to accomplish. So to stitch or not to stitch. So what stitching is the upper part of the scan is taken, and then the machine kind of resets and then takes the lower part of the scan and it stitches it together. So you can take a mid-size field of view image and stitch it together. But this is the problem. This can be the problem with stitching. So here's the floor of the nose right here, and you can see the patient moved, and there's the floor of the nose there, and there's this hazy overlap. And so that's the problem with stitching. And some would say, oh, that's patient movement error 100%, and I would agree 100%. However, if you had me this particular image, patient had to sit for a minute to get it stitched together, I'd probably move in a minute. I can barely sit still for 5 seconds, let alone a minute. So that's the concern with stitching. So you just have to be mindful of it. Now, let's say you're just doing implants, or you're just doing it for endo, and you have a machine that has a capability of stitching for some rare circumstances. Okay, well, that makes more sense, and you know that this is a risk when you do it. But if you're going to typically be acquiring an image this big, doing ortho, TMJ, or sleep, then you really want to take that into account and maybe not have a unit that stitches. So applications, tons and tons of applications that I'm going to go through briefly here. So in general dentistry, I really do think that with the dosages, how low they are, I don't really see a need for a panoramic film anymore. Me as a patient, my kids as a patient, I don't know when I would take a panoramic film over a cone beam of low dose. I was talking to a surgeon today about that, knowing that I had the webinar. I said, hey, doc, give me an example of why you would want a pano over a cone beam. And he's a surgeon, so he said, well, for a quick checking angulation of an implant. And I said, well, if you could take a quick cone beam, same amount of radiation, why would it be different? Now, I know panos traditionally have a 2D pano looks better coming from a 2D pano machine than a 3D machine. But again, I would rather have a 3D image to move around, manipulate, and look at than the flat panoramic film. This is an image I actually rarely look at because I'm always looking at the 3D image or sliding through the condyles. But very rarely do I find much value other than counting teeth in that panoramic image. And all cone beams you can extrapolate a panoramic image from. And so if you want to charge a panoramic fee, you are taking a panoramic, you're just taking more data as well. Endodontics, I showed you 2 cases already that where I've seen patients that have had retreats and we find a missed canal. We've seen fractures. We've seen periapical lesions that are covered by the cortical bone that you wouldn't see on a PA. And so really in endodontics, again, I think this is going to become more and more standard of care in the endodontic world, just like it is in the implant world. I think it's tough to argue that doing implants without a cone beam, tough to make that case anymore. And I think the same goes for orthodontics. I had an interesting, an orthodontist I know called me and said, hey, I'm going to start ortho on my son, and I'd like a cone beam before I start. And can I send him up? I was like, yeah, absolutely. So, or send him down, I should say. So the orthodontist sent their child down for an image, and I called the orthodontist and I said, hey, I got to ask you a question. So you're okay treating other people's kids without a cone beam, but you didn't want to start ortho on your kid until a cone beam. And the orthodontist said, that's a good point. I'm going to get a cone beam. And they got a cone beam. So I think we're going to learn that this is more and more common for evaluating an orthodontic patient. And I'll show you some slides in a minute about the dosages. And then TMJ and sleep, I could show you case after case after case of the value in using it for that. And then oral surgery, again, wisdom teeth, impacted canines, pathology. We know there's huge indications and more surgeons are having that. So, some things that we need to know when we're imaging this is, a lot of times we're going to capture the nose, capture probably the bottom half of it. And so I thought it would be valuable to explain some of the principles that we use the cone beam to explain with patients in making adequate referrals. So Bernoulli's principle tells us that air increases in speed, leading to a decrease in pressure. So when you have higher pressure at a lower speed and the lateral walls pull in, you get lower pressure at a higher speed. So that's that snoring effect, if you will, of when the walls of an airway collapse and they start to reverberate. You get a lower pressure at a higher speed and the walls collapse in. So if you're looking at, I always tell patients, picture a milkshake. If you suck from a milkshake slowly, the straw doesn't collapse in, but if you do it fast, it'll collapse in. Pascal's law tells us that flow rate increases to the 4th power based on a change in radius. So if you change the radius of a lumen that has gas or air flowing through it, fluid, the flow rate will increase to the 4th power by a change in radius. So we can have a minute nasal obstruction or soft tissue inflammation that will make a huge effect on the airflow. And so since we're going to be imaging these things, I think we should be comfortable with evaluating the basics. And I think the best way to understand how an ear, nose, and throat doctor looks at these images is to grab some images and sit down with an ENT and just say, hey, tell me what you see. What type of patients should I be referring to you? If you see X, do you want me to refer to you? If I see Y, what do I tell the primary care doctor? So stay in your lane for sure, but educate yourself on where the lanes overlap. Because like I tell every patient, the bottom half of the nose is the top half of the jaws. So we are evaluating, when we're evaluating the maxilla, we're actually evaluating the lower part of the nose. So we do need to be comfortable looking at these things. So as we look at flow rate, this is my ENT. This is interesting. So this is my wife's nose. Doesn't look that bad, swollen, slight deviated nasal septum. But a CT, we have to remember, is a volume average of slices then strung together. So she had a lot of nasal issues, congestion, and she really didn't know how bad she was breathing through her nose, but knew enough that after doing nasal sprays and stuff, she'd get it fixed. And so here's how much bone was taken out during her surgery. And it astounded me as I was in the surgery. So this is the cartilage from the front part of the nose, the cartilage strips that they do to make access and straighten the septum. And then this was all the bone spur along her septum that was obstructing her breathing. And so what I've learned most from the ENTs is that bone spurs on here can be a lot bigger than they look in the image. And you can't just rely on this to evaluate the flow of the nose. A good clinical exam and a scope by an ENT is the best, but we can ask good questions to make a proper referral. So just like the airway of the throat doesn't tell us if there's apnea or not, we have to do a sleep test. Ear, nose, and throat doctors need to do a more detailed exam, but certainly, I mean, this really put in perspective of how much we can miss in these cone beam scans based on that amount of bone that was taken out. We know that nasal airway resistance and body mass index are the two most important predictive factors for a mandibular advancement splint treatment outcome. So when we're treating these apneic patients, if we know that nasal resistance is one and body mass index are important predictive factors for success, well, we better have a way of evaluating that before we start rendering treatment to these patients. So whether it's with surveys, asking questions, doing a physical exam with nasal specs, it's in our scope, as it's the jaw, to look and evaluate the nose and make a proper referral. But discuss it with your ENT and come up with a local protocol, again, so you're staying in your lane, but you're really helping collaborate with these patients to a whole new level. So, you might see a nose like this and you'd say, well, how do I know if I should make a referral or that should be fixed? If you just stop at saying, how do you feel you breathe through your nose? You might not get very far. So this patient, we understood that a lot of her symptoms were her nose, even though she didn't know it. She trusted us and we made a referral. So she had her nasal septum fixed. And so here you can see the deviation with the bone spur. And then here you can see, I tried to get the closest cut of her first molars. And here you can see that the bone spur is now gone. And so this is her feedback on the procedure.
This is Andrea. She agreed to send you this quick message. But Andrea, tell me about, from your first appointment, we told you your nose was blocked and then you got it fixed in June. How does it feel?
3 days after the surgery, I can breathe. Like, I had no idea that I couldn't breathe before the surgery. It was amazing.
Now, did you think I was a little nuts when I told you couldn't breathe through your nose?
A little bit, yeah.
Yeah, okay, cool. But you still came.
I still came.
Great.
Yeah, did it.
Persevered.
And I feel so much better, and the surgery was super easy.
Awesome.
Like, no Vicodin, no narcotics, just Tylenol and Advil, 3 days of rest, and I was up and about.
Awesome. All right, thanks, Andrea.
You're welcome.
So what's cool is now these nasal procedures are super conservative and patients do great with them. I had one, my wife had it, we had them on Friday and, back at work on Monday. So, a lot of times we'll see kids for sleep issues, and you can see here this sweet little girl can't really keep her lips closed and mom can't figure out why she's sleeping. So we were doing an orthopedic development evaluation on her. And so we elected to order a cone beam image. And mom agreed. Mom's a nurse. And mom had brought her to the primary care doctor for her sleep issues, but she had no symptoms other than mom said something's wrong with her sleep. She wasn't snoring. She wasn't complaining of congestion. She wasn't complaining of a headache. She wasn't getting sick a lot. She just wasn't staying in her bed and wasn't sleeping. So when they came to us, mom was astounded to see that her sinuses were basically 100% full of bacteria and gunk, and her ethmoids even, and then her adenoids are extremely swollen. So this poor little girl wasn't sick enough to get an image in a doctor setting because she didn't have enough complaints. But while we were evaluating her orthopedic development, we were able to see this and get it treated. And the cool part is we treated her in about 3 months without any antibiotics or surgery just by normalizing breathing, her adenoids are still swollen, and she was worked up by an ENT and followed up and everything. So the adenoids improved a little bit, but what's really cool is we were able to establish lip competency, treat her with myofunctional therapy, and really change this little girl's life. And I firmly believe we would have had to somehow get an ear, nose, and throat referral for no symptoms before we saw that. Now, it all made sense once we saw the image. And so, we have a lot of cases like this where it really helps steer us on the treatment plan. So how did I learn to read these images? So there's a lot of good resources out there. There's good books, there's good courses, there's gobs of webinars, but I really think the best way to learn is when you take an image, read it yourself. So I have a protocol from my mentor, Dr. Olmos, where this is our informed consent, the size that we take. This is a drop down in our software, so we can pick the size that we take. So our normal, I'd say, is 16 by 13 and 0.3 voxels. But I'll look at the dentition. If there's anything abnormal, I'll type it. I look at the nose. Anything abnormal, I'll type it. Look at the sinuses, the airway, the cervical spine, the jaw, TM joints, alveolar bone, additional findings, and I'll render my clinical impression, and then if a referral is recommended. So a referral to an ENT is highly indicated due to the nasal issue, the deviated septum we saw. So this is a protocol that I just kind of spot check as I look through the scan so I don't miss anything. Then what you do is you send it to a radiologist. This is Dr. David Hatcher and Bruce Howerton. You can send it to a radiologist, and they can overread your scan, and you can compare notes, see what you missed, get advice, get greater detail, and then go back and look at the scan and really understand the anatomy of what you just captured. So I think that's a tremendous opportunity to learn scans. So here's Brandon. He's a 30-year-old, came in last week with jaw pain. Kind of looks like something fishy's going on with how asymmetrical he is. So we got ourselves a cone beam, and you see right here, he's got this gross asymmetry, elongation of the ramus. Looks like he's got some long-standing degenerative changes on the side there. And when we get his radiology report, he's got a hemimandibular condylar hyperplasia and an osteochondroma. So he's got this outgrowth on the lateral aspect of the condyle that is just like a mass that also is associated with this elongation of the ramus. And so while his left side looks relatively normal, this has been brewing for a long time. He's been to the dentist, he's had imaging and all of that, but never was able to get to a diagnosis of osteochondroma on the right condyle. So, he's getting worked up for jaw surgery. We just saw him last week. This is Stacy. We saw her a year ago. Had pain, been to diagnosed with rheumatoid arthritis, been to a pediatric and general dentist, 2 oral surgeons, and then an orthodontist referred her to us. We did her workup. She's got juvenile idiopathic arthritis on the right, where the condyle is just kind of mutilated. And then the most valuable part of this scan, actually, because, on a pano, we could see that something's really wrong here. But one of the most valuable is her pain was on the left. So she actually has active joint degeneration going on the left, where this is a long-standing, more arrested process. But this is where she's actively hurting. So she's got some active degeneration going on, some cortical erosions on that left side. And so, here's another little girl we saw with the anterior open bite, despite having fixed retainers. And so the orthodontist, before they started phase 2, wanted me to evaluate their breathing and work with their tongue posture. And so here we were able to close her open bite with myofunctional therapy, no braces or retainers or appliances, just with myofunctional therapy. And then the argument is she just posturing forward, and what movement did you actually get? Well, the only way to truly evaluate what movement you got is to look at a cone beam. So you can see the torque of her incisors did change, but the mandible position, she wasn't just posturing forward, because if we look at her condylar position is still sound. So we actually got some good bodily movement of the teeth, which we know the tongue does. And then we can actually quantify where that movement happened, where with pictures in a pano, you wouldn't be able to quantify all that and see the joint position as good as you do here. So what are our limitations? So here we have the mandible, and then we have the articular disc, the retrodiscal tissue, and then the pterygoids. And so what can we see? We know we can see the bony structures, but we can't see the articular disc. So the articular disc, if you look up here, on the top left, there's the cartilage in a normal joint as you open and close. In the middle here, you see a medial displacement disc, where you'll see the disc pop into place on opening, and there it is. So we cannot see this stuff on cone beams. We can see disc space, we can see joint position, but we can't see the articular disc. And so this case is a great example. This patient came in, hard end feel after falling on a treadmill. And he's got some flattening of the condyles, shows some wear and tear, but he fell last week. Maybe the joint's swollen. It's not seating all the way in the space it looks like. Maybe he's posturing forward due to the pain. Tough to tell. So we get an MRI. As we look at the MRI, the left side here, the cartilage is normal. So this is the mouth open view. Cartilage is in the right space. Mouth closed, he's dislocated on the right. So he's got an anterior disc displacement, and then on opening, it reduces. Well, let's look at the left side. Left side, 1, 2, 3. The disc is shattered into 3 pieces, and that's why he's having so much pain and difficulty closing. There's no way I'd be able to see this with a cone beam. So oftentimes in the presence of trauma, you really want to consider getting an MRI so you can see these tears and fractures of articular disc, because on a cone beam, you're not going to be able to see it. So we can merge these data sets with STL files. So you can take a Trio scan, take your cone beam, and through Trio software, multiple other softwares, and merge those data sets, pick points of reference, and then merge them together for various treatment plans, orthodontics, implants, and such. So, I mean, the capabilities of this technology seems to be endless. But again, really important to know the technology opportunities that you have and utilize them to the fullest. So the radiation concerns. So this article from the American Academy of Oral and Maxillofacial Radiology talks about the use of cone beam in orthodontics, and this is the position statement. And the position statement states that this should be periodically revised to reflect new evidence, and without reapproval becomes invalid after 5 years. Well, this was 2013. I haven't been able to get my hands on an updated one, but this is a good reference for people to understand what the position of the American Academy of Oral and Maxillofacial Radiology states. And in here, it shows a lot of dosages, and I put together some summary slides for you guys. And again, render your own conclusions on all of this stuff and research it yourself so you understand it. So a flight to London is about 80 microsieverts of radiation, and a CT for upper GI is 6,000 to 8,000 microsieverts. And usually the dose we're taking, you'll see in the next slide, or in 2 slides, is about 80 microsieverts. So here, the risk of medical imaging at effective doses below 50,000 microsieverts for single procedures and 100,000 for multiple over short periods of time are too low risk to be deterrable and may be non-existent. So this is saying that 50,000 to 100,000 microsieverts is non-existent. And then this says exposures below 100,000 microsieverts compatible with no changes in cellular repair mechanism. So again, below 100,000 microsieverts is what this article states. So traditional standard imaging in orthodontics, a pan-ceph is anywhere from 6 to 60 microsieverts, and ICAT Flex 6x11 is 43 microsieverts. So in my opinion, if my child's going to get evaluated for ortho in this range with a pan-ceph, I mean, I would rather see much more information for a radiation dose that is comparable. Might be less, might be more, depending again on the machine you have. So definitely something that you'd want to take into consideration, because in my opinion, why take a pan-ceph at 60 microsieverts when you can get an ICAT flex? Now, if you're concerned about liability, many ways to pacify that concern: have them all read by a radiologist, have the patient sign off, have the patient pay for it, whatever works. I had easily my first 500 to 700 scans read by a radiologist, and now I still send scans virtually daily to the radiologist for a second look, a second opinion, so that I don't miss anything. So here's just a chart. This is typically the field of view that we take, and we'll take about 80, I think it's like 67 to 87 microsieverts of radiation. But these are kind of the scans that I live in for our imaging, and so our standard is 79 to 85 microsieverts, but we can dose it down all the way to 9 to 11 microsieverts if we don't need much detail. So if we're spot checking something, or we're verifying condylar position, mid check during ortho, and we're changing the condylar position, we'll take a more grainy quick scan, and that just lowers the scan time, which lowers the resolution. And so, again, you can have access to all this information so that you're making informed decisions for your patients. So what more can I do for you? Number one, answer some questions. Happy to. Then also just want to share with you that, I have written 2 books. One book's a patient forward book. So we send this to all of our patients before they come in. It goes through 10 stories of cases we treat, how we treat, our thought process in the clinic, and how we really want a patient experience to go. And then wrote a book on steps to having success integrating dental sleep medicine into your practice. So, I always want to have people leave with value. And so if you want or interested in reading more or want a copy of the books, I'm happy to send them to you. Just text Clower to 21000 and we'll get that information. So I see a lot of questions, so I'm going to jump to those. And I'm going to start at the top. Do you recommend to take CBCT for all orthodontic patients? I think all is tough, but I would say oftentimes I see there would be an indication if you're going to take a pan and a ceph, and you can get a cone beam for the same, if not a reasonably great, like a small amount greater radiation. I don't see why you wouldn't. And again, that's my opinion. But I know a majority of orthodontists are just have a cone beam in their office, and they don't have a pan ceph. I know it's different at the academic settings where they have tons of different machines. But if I was an orthodontist starting scratch, I would not get a pan ceph. I would get a cone beam undoubtedly. What is the radiation amount comparison of 3D compared to 2D FMX into a Panorex? Well, 3D is less than 2D FMX and Panorex for sure, but it doesn't give you all the info. So I still think FMX is indicated to check bone levels as a restorative dentist and stuff like that. But I just don't see the need for a Panorex much. And I'm open to discuss that with someone. I just don't really see where there's a role for it with how low a dose these cone beams can be. Liability for non-dental lesions or for failure detection. So the jury's out on that. Some attorneys I've heard speak from the podium, and they say you're only liable for what you can diagnose. So if you can't diagnose something, then you can't be responsible for it. I've had others say if you capture it, you're liable for it. So I would say speak with your malpractice carrier and speak with the physicians around you and have a game plan. Are you going to send everything to get read? Are you going to send only certain things to get read? I mean, we've seen a malformed cervical spine that led to immediate surgery on a patient because their spine was so unstable at risk death on a pediatric patient. That was picked up by a radiologist. I didn't see it on my scan, but we sent that scan to a radiologist to have it looked at, and glad we did. She had surgery 4 days after we took the image. And I would argue that if we would have taken a traditional pan ceph, we wouldn't have seen that image. And the doctor said she was a pillow fight away from dying, meaning if her sibling hit her with a pillow during a pillow fight. it could have killed her based on where her malformation at C1, C2 was. What's the difference in radiation between this and the live CAT scan? So CAT scans in the medical setting can be up to 10,000 microsieverts, whereas the cone beams that I was showing are in that 80 to, call it 80 microsievert range. Best place to get information, a course, a book to help learn oral, facial, and airway anatomy on CBCT. What is the normal and what is not? How to manipulate the cone beam scan to diagnose anatomical issues. So Grace Petrikowski has a great CBCT anatomy book. I know Beam Readers and iCat have a lot of online modules that you can do. I'm more of a kind of touch feel type guy. So if I get a software, I get to manipulate it, the screens myself, move the images around, and then read them myself and have a book out. I think that's the best. There are some great programs. Dr. Howerton has one where it's like a live scan and you click on the structure and it tells you exactly what the anatomy is. That's really cool because you know what to see. So I'd say Grace Petrikowski's book, and then looking online for iCat and Beam Readers and the Oral Radiology Academy has some good information out there too. What's the minimum field of view for a 3D pano? Is 9 by 11 good? Typically it is. The smaller the field of view you have, the more important patient positioning is. And so you'll kind of dial it in for pediatrics, adolescents, and adults. So you can have up to 3 different like sizes for a good pano. But you want to take some images, give yourself feedback, and make sure that you're capturing everything that you need. Next question. What are some of the symptoms of nasal bone spurs other than open mouth posture? There's a lot. So postnasal drip, anterior open bite, narrow arches, crooked teeth, the nose score, NOSE, nose score, is indicative of nasal obstruction. Smell issues, coated tongue, tongue scalloping, tons of indications for it, sometimes associated with GERD. And so that's where I think really sitting down with an ear, nose, and throat doctor when you have some scans to go through is huge. And my wife was a great example. She was congested a lot and stuffy, and I could hear the resistance, but she didn't complain about it. And after her surgery, she basically said, "Oh my God, I had no idea I couldn't breathe," just like that lady I showed in the video. That lady in the video I had to plead her to go to the ear, nose, and throat doctor because of what I saw, but she didn't really see any need to go until I spoke with her. All orthodontists, what was your treatment for the little girl with enlarged adenoids and blocked sinuses? So all we did was myofunctional therapy. So we just rehabituated her to breathe through her nose. She was diagnosed with mild apnea. In utilizing a MyoBrace myofunctional appliance and myofunctional therapy, her sinuses cleared up and her apnea was treated. And then she'll see an orthodontist eventually, but we were able to treat her just with myofunctional therapy and a myofunctional appliance. So how did you treat the little girl? That's how we treated the little girl. I published an article on that case. I'll have Heather from my team send it to Viva as well, and you can walk through the whole case. Could you please name the textbook for reading CBCT? Yeah, that's Grace Petrikowski's CBCT Anatomy. I will, I'd butcher the spelling of her name, but she's from, Dr. Petrikowski's from Canada. So it's Grace, Pietro Petrikowski. If you Google it, you'll find it. What do you mean for myofunctional therapy for the closure of anterior open bite? Oh, yeah. So a lot of anterior open bites are due to a tongue thrust. So if the tongue can be strong enough to open the bite, the tongue and the lips can be strong enough to close the bite. So with that little girl, once we positioned her tongue to be in the roof of her mouth, her tongue pushing on the palate at the incisive papilla and her lips adequately closing, repositioned her teeth and closed her anterior open bite. And we see that all the time in our practice in treating with myofunctional therapy. If you have specific questions, Kelly, please feel free to shoot me an email. All right, next question. What software is needed to merge DICOM with STL files? Great question. So 3Shape Trios has a software that does it, so you can just merge the data sets. And I believe most STL image capturing softwares have the capability of doing it. I'm familiar with the Trios one, and that's it. But I know there's tons out there. So I would just chat with your vendors and ask them specifically. What's the cost to have a radiologist read each scan? I think the going rate is typically $50 to $95, depending on who's reading it, how many images you send, and then also what type of report do you want? Do you want screenshots or not screenshots? Screenshots take the radiologist more time to capture and show and put arrows on. So it really just depends. But I'd say 75 to 85 is probably the normal going rate. Dr. Clower, could you please place the slide with the text code up? So I'll just type the answer. You'll text Clower to 21000. So I answered that one. Thank you for your lecture. How can I make a diagnosis for maxillary sinus with cephalometric image? You really can't. Unless it's super, super cloudy on both sides, you might see it. But on a Ceph, you won't be able to see the anatomy like you can on a cone beam. For trauma injury, possible broken jaw, possible or condyle fracture, is CBCT the best option? Oh yeah, hands down. Is there another image needed than like an MRI? Yeah, I mean, like those two cases I showed were great reasons for an MRI. The cone beam ruled out that he didn't fracture his condyle, but it really didn't give me a depiction of the disc. And so that's why we got an MRI. So I think, again, I don't see the need for a panoramic film. If I suspect a trauma, I would want a cone beam or go to the hospital and get a hospital CT, especially if it's a car accident or that type of trauma. You want to make sure there's no bleeding and really the crazy stuff. So having a hospital-based CT scan or talking to a physician about is it appropriate is definitely something you want to consider for trauma, and have a checklist to go through just so you don't miss anything. Do you use the CBCT for airway eval other than nasal, and if so, how? Yeah, we do. We look at the airway tool in the treatment studio. We measure it. And we look at it and discuss it with the patient. How can we get certified for CBCT? It really depends on your state, country, if they offer certifications or not. And so really just kind of depends on what you mean by certified. But to get comfortable reading them, send them to a radiologist and get comfortable with that. The checklist for CBCT, yeah, what I would do is if I go, well, my screen share's off. In my presentation, you'll see my radiologist report. I'm going to send you my PDFs. In that radiology report, she has a checklist, and that's what I follow. So dentition, nose, sinus. So actually, it'll be in my slide deck. You'll be able to see that. So you'll have that checklist. Taking a cone beam can show if you have sleep apnea. No, it can't. I'm going to make sure everybody hears me on that. A cone beam will not show if you have sleep apnea. I've never stated that, won't ever state that because it can't. We see people with big airways that collapse at night and have apnea, and we see people with tiny airways that don't collapse at night and don't have apnea. So it's different. Can the OP 3D stitch two field of views together? Depends on the size. I'm not sure exactly, and I apologize. I know the ICAT really well. I don't know the other ones. In my opinion, if you're going to be asking about stitching, just get a unit that doesn't stitch, because I think it proves to be an issue more than a good thing if I would just upgrade the field of view. There was an interruption in my connection. Please repeat the software merging data question. Oh, so the software merging is 3Shape Trios does, but I would also check with your vendors on what that is. One more time, let me look up Grace's name real quick while I have you guys here. I can Google it and find it for you. CBCT Grace. So the book is Diagnostic Imaging, Oral and Maxillofacial. And it is Grace Petrikowski, and there's some other authors as well. And I'll put that that link in. I'll put her name in the chat box here so everybody has it. Thank you for your patience with that. Here it is. Oh, let me answer that. Type answer. I'll put it in the chat feature. Dr. Grace Petrikowski. Okay, I was told one more question. As a general dentist, if a patient constantly complains about TMJ pain and there's no dentist who treats TMJ issues, what's the next specialist you would refer to? Oral surgeon? I would say an oral surgeon or an ear, nose, and throat doctor, because a lot of these nasal or a lot of these TMJ problems are due to upper airway obstruction or associated with upper airway obstruction, and we find that beneficial to work with an ear, nose, and throat. But I would call some of the oral surgeons or orthodontists. Sometimes orthodontists are comfortable and like treating it, so I would go there too. So if anybody has additional questions, please feel free to reach out. I am told that time is up, so thank you everybody for attending. I hope you found value in the presentation, and appreciate the opportunity, and hope everybody has a safe night and an awesome weekend. Thanks.